Medical information on this site is provided as an information resource only and is not to be used or relied on for any diagnostic or treatment purposes. This information does not create any patient-physician relationship and should not be used as a substitute for professional diagnosis and treatment. Please consult your healthcare provider before making any healthcare decisions or for guidance about a specific medical condition. Doctors Ruhoy and Kaufman shall have no liability for any damages, loss, injury, or liability whatsoever suffered as a result of your reliance on the information contained in this site.
Hi, we're back. We never really left, but this is going to play separately, so I just wanted to...
I changed. And,
What's that?
I went home, I changed my clothes.
Showered, put on the same clothes.
Right.
Yeah, we never really left, but this is obviously going to play at a separate time. So this is part 2 of our continued conversation, which started out about PEM,
Right.
post-exertional malaise.
And we quickly left it, as we
We
usually
always do.
and rambled and
I know, but it's not,
tangented.
but I still think it's like peripherally
It's all
associated.
related.
Yeah,
It's
it's
all
all related because, again, the complexity of these patients and the interrelation of the septad diagnoses, I think these are very important points that we regularly drive home. And so the fact that we seem to be focused on PEM but seem to be talking about other things is still focused on PEM, in my opinion.
Right.
And so we were talking about the mind-body connection. There is PTSD. And I do want to just I wanted to just bring that back for a brief moment. Because I often will talk to patients about this idea that when you get better, because I always believe they will, because there's always hope, and we both know that we see patients get better. Sometimes they get better 50%, sometimes 80%, sometimes 90%, sometimes 100%. And there really is a PTSD to have to contend with because there's such a change of the quality of life and the functionality of their lives that it's something they never really get over. And it is what instills that panic or that fear that I was referring to at the end of the last episode, which is sort of they live in this fear of like, was that a PEM symptom? You know, was that...
Keep in mind that PTSD, mind-body, panicky response is basically the same fight or flight, the tiger's chasing me, as when you stand up and your blood pressure perfusion drops and your brain says, oh my God, and pours out signals. So in a sense, your brain is responding with a sympathetic output and your adrenals respond, and there you are.
Absolutely.
You're in it again.
Yeah, you're in it.
So,
it's right. You literally are back in that spot where you were.
Which doesn't mean we need to medicate that problem away with benzos, although they are remarkably effective for this.
For sure.
Just so effective.
So is ketamine, by the way.
Yeah, but not as easy to
access.
Right. I don't have enough experience. But it also means that there are other interventions. So I remain almost daily pleasantly surprised by the benefits of the brain plasticity programs and exercises. All right, some of them are a pain in the neck, some of them are too much work or difficult, whatever, but they work.
They do work.
Really
they do
patients.
Work. Yeah, and I think that's an important thing to discuss with patients because they have to recognize that while we'll work to get them better, there's always going to be this level of PTSD, but there are treatment options, and that's something that I think at some point along the road of recovery we start to implement. Right, we shouldn't wait until we feel like they're as good as they're going to get, or they feel like they're as good as going to get, and then to deal with the PTSD, which could then, by the way, be the reason why they all of a sudden relapse or regress.
And full disclosure to the listeners, every time I start to bring that up, I have anxiety of my own because I dread the patient going into he just thinks I'm crazy. It's all in my head. And it's just, and I can't, I'm sure that's what happens. And I try to introduce it and say, look, I know what you're going to think, but this isn't what I'm saying. I am saying there's a connection. There's ways to deal with this. It's a real challenge because they've been so gaslit and so burnt for decades.
Yeah. No, that I agree. They are very sensitive to any doctor telling them that there is some level of, PTSD has always been considered a psychiatric diagnosis, but I don't see it as that. I just sort of see it as a consequence of a severe trauma related to their bodies and to their health. And so, and I try to sort of couch it in those kinds of terms, like you've been through, you and your body and your psyche have been through a lot.
It's a wiring issue.
It's completely
a synaptic wiring issue. It's a vagal
which then I
issue.
guess makes it a neurology.
It's real.
Neurological diagnosis.
No, it's real.
No, it is real. But and by the way, it happens to a lot of people for a lot of different reasons. I mean, veterans, of course, PTSD has been largely studied in veterans and those especially with combat experience. And so there, it happens because of things that they've not only that they've experienced themselves physically, but even things that they've witnessed. That can trigger a PTSD kind of picture. I mean, I have PTSD from my brain surgery.
I can imagine.
So it's not, yeah, so I agree. This is not anything to be ashamed of, or it's something to embrace, because it will affect how you move forward, right? If you're so triggered by a particular symptom or feeling that it sends you into panic mode, or as you said, a sympathetic, flight mode, it could really affect your physiology to the point where you could potentially relapse. Because I do believe that even though we can help patients get better and get them on the road to recovery, I very firmly believe that they remain sensitive, that their bodies and their cells and their tissues remain hypervigilant to other dangers that might present. And, we can refer to it as the cell danger response. There's a lot of other phraseologies for it now, but I think that they're always hypervigilant. They're always hypersensitive. I think they're more at risk of developing it again than someone who had never had ME/CFS, or someone who had never had a fatiguing illness, or someone who had never had.
The pathways are there.
The pathways have already been paved.
And that's not, you're the neurologist, but that's not a made-up concept. I mean,
no,
that's
it's
what
not.
learning is. Learning is establishing the synaptic pathways. That's why you practice a piano, or you practice reading and stuff like that.
In many ways, it's sort of like addictions. And I sort of don't want to liken it to that kind of disorder, but we don't really understand addiction. But we do know that there are certain pathways that are formed that will forever be there, which is why it's easy for addicts to relapse. And so you work really hard to try to basically pave over those pathways. And there are ways that have been shown to be effective at doing so, but it takes a lot of effort, a lot of motivation, and a lot of time. And so that's why when a patient relapses after a particular surgery, I go looking for reasons why, because there is no other physiologic reason with that timeline, with that duration of time for that relapse, than to find another physiologic anatomical problem. But I'm talking, so when they're sort of, well outside of that range, what could have happened that have triggered a relapse? And I think that's just one thing that could trigger. I mean, there's lots of things that could trigger. Of course, another viral illness, God forbid. I mean, that's always my biggest fear. It's like, you have to protect yourself. And then we get into this whole conversation about vaccines and stuff. And a lot of these patients are terrified of the vaccines. A lot of these patients felt that the vaccine made them worse, or they're even, they know of people who are vaccine injured. And so it just becomes and that's why I think the relationship between the doctor and the patient is so critical, because there needs to be that mutual trust, so that when we say, listen, I think we need to address what clearly is a level of PTSD over what you'd been through, which is completely a normal and natural response and is to be expected. We need to address it, that they trust us enough that they're not immediately assuming that we think that it's all related to their, anxiety or their depression, or that we think that they're crazy, because we don't.
Let's move to the 800-pound gorilla in the room.
Okay, which is what?
Mitochondria.
Oh, the mitochondria.
So, in no way diminishing the extreme importance of everything we said in the previous episode, this multifactorial, all this other stuff, we need to discuss mitochondria.
Yeah.
So, I mean, you're a mitochondrial expert, so you probably should be talking, but I'll start by saying mitochondria are in every cell in our body. They have a greater density in higher oxygen consuming or energy consuming organs, such as the brain and the heart and the lungs and the muscles. What happens in post-exertional malaise and ME/CFS? The brain stops working, the heart is not able to do maybe what it should be doing, and your muscles are for shit. They're just not working. Excuse me, I'm sorry.
Well, they are, you're right.
My New York is out in spades today. That's because I just was in New York. That's what it is. I visited family in New York.
I love it. I miss it so much.
Sorry if it bothers anyone. And I don't think there's any argument about this, that it's mitochondria. It's about, it's like Clinton with the economy. It's the mitochondria.
Stupid.
The problem is, what is it about the mitochondria? What is the pathology? And what do we do? I mean, I have patients like you who come in with 2 pages of supplements. Mm-hmm. Oh, that's for my mitochondria. I don't know that any of those get into the mitochondria or do anything.
They don't.
So it's
they don't. I mean, I think that this is where a lot of it goes wrong. And we did do sort of a podcast that focused a little bit on mitochondria, and we talked about the cocktail. And I did bring up the experience when I was at Children's that in the mitochondrial clinic, that a lot of these children who had mitochondrial diseases, with true mitochondrial genetic variants and mutations, did seem to have some improvement from the cocktail, at least by the parents'
Yeah,
report.
but I think it's a completely different population.
And that's what we said. We basically said this is a completely different kind of mitochondrial concern. And so I don't see a lot of improvement with the mitochondrial cocktail supplements. And I always like to point out that my cocktail recipe has changed over the years largely because of that, because I wasn't seeing the same kind of response to sort of the classic cocktail. So just based on what I know about mitochondria and its function, and then what I've learned about this patient population, I've sort of changed it over the years. I will say that the IV form of what I use as a mitochondrial cocktail does seem to have an improvement in effect. And in fact, I regularly get it myself. So IV form, it's much more bioavailable. These supplements, over the years, I've learned that most of what we think we're consuming, we're not getting. They're not highly bioavailable. In fact, there was one study that sort of did mass spectroscopy on LCMS, so liquid chromatography mass spectroscopy. That's a lot to say. And they found that, in the same bottle, every capsule had a different amount of the compound that you were buying it for, and some actually had none. Some of those capsules had none of it.
And some had other things.
And some had other things, right, exactly. So I think that they're not highly reliable supplemental form of anything in particular. I mean, there are some brands that are well vetted and well touted and have high respect, and they probably are of higher quality for sure, but I still think the bioavailability is low. And then on top of that, that's in general bioavailability. So what's extracted through the GI tract, because you're taking this orally, there is first pass metabolism through the liver. So overall, what's bioavailable, I'm saying, is less than what we expect.
What gets into the mitochondria?
And then, well, that's the added level, as I'm saying. And then what gets to the mitochondria is a whole other thing,
Which has
right?
to get through the cell membrane.
It's exactly
through
right.
the cytosol.
It's exactly right. And the mitochondria, I mean, they have obviously a double-layered membrane as well, and so they too, and that the reason why nature tries to protect them is because they're so critical to the functioning of the cell, right? So they try to assure that things that shouldn't come in don't come in, and things that should stay out stay out. So that's saying the same thing, I guess. But so I just think that what you're taking doesn't get to the mitochondria, I guess, is my overall point, which is why I don't think we see a lot of improvement from oral supplementation. I mean,
this is probably a bolder statement than I want to make, but I'm going to make it. I think I've only seen what I perceive as mitochondrial benefit with two supplements, okay? One is CoQ10 or ubiquinol. I think I've seen that help, but maybe that's not through mitochondrial function. Maybe it's something else. I don't even know. And then, to my astonishment, when we did this work with oxaloacetate, I never thought that would help. I never thought it would get anywhere, all right? And the only thing that convinced me to try to do it was this data that suggested the level of oxaloacetate, a key metabolite in the Krebs cycle, was deficient, was lower than normal in ME/CFS patients. I said, well, that's interesting. Let's see. Not really believing this product, it's a commercial supplement, would go from mouth to mitochondria. But we had great results. And it's the only one I've seen that actually had some proof, and now the same proof is showing in the randomized placebo-controlled trial that it was beneficial. Is it because it was the right metabolite, a supplement, or is it just something magical about how it got into the mitochondria? I don't know.
Right.
But it did help.
Well, I mean, the Krebs cycle is one of those cycles that do feed the mitochondria, so it is interesting that it's one of those intermediates of the Krebs cycle. Right. And so what was reported in this study? What were the symptoms that improved?
Fatigue and brain fog, primarily. And in the placebo-controlled trial, which is still ongoing, we reported the interim stuff. It's 80 patients, and we reported on the first 40. And in that trial, what was really interesting is not only using the fatigue measures, which are, they're validated and everybody accepts them, but it's still like, do you feel less tired? It's not very scientific. They had a device that measured time that patients were not reclining, called uptime. And there you see this quite dramatic, at least in the initial interim, difference between placebo patients' uptime and oxaloacetate patients' uptime, where they were able or just did it. They were up more. They were vertical more often.
Yeah, that was a fascinating study. I mean, and you were one of the authors of it. Yeah, no, I loved reading that paper. And we regularly recommend the oxaloacetate to patients.
The problem is it's just so damn expensive.
It's very expensive, but they also need high dosages of it.
Yes,
so, yeah.
So, but I still think it's At least that has some
No,
evidence.
I completely agree. So we're right, and we should study some of the others. But and you're right. And what we're referring to, which is that we don't really see much of a benefit, it's really, we should say it's anecdotal and empirical, and we haven't really studied it in that kind of more controlled manner.
So this is a fairly negative thing we're saying.
Right.
Let's acknowledge it. That all those 2 pages of supplements you guys are all taking probably isn't doing much.
Right. It doesn't mean it's not the mitochondria, of course. It just is, that's not a means of treating it.
And I always worry, and I will say, not only am I not sure it's doing anything, but if you have MCAS, mast cell activation syndrome, all that crap that's mixed in those pills, who knows what it's doing? How many times is it activating your mast cells and you feel worse, but you don't blame it on your pill because you're taking that to feel better. You blame it on, the lights in the room or something.
Right.
So it's very difficult. And it is, I recognize that I'm saying something negative and it's not encouraging to hear, but I think we need to acknowledge it so we can move forward and discuss other things.
Right. And right. I completely agree. And I think people are wasting a lot of money on supplements, and that really bothers me.
And I've never quite said it, but I almost say, well, if you just don't spend the 2 pages of money, you can afford to buy the oxaloacetate.
That's true, actually.
Which at least has some evidence. And granted, I may be biased because I did the study, but now the Salt Lake City study at Bateman Horn, that's a real elegant scientific study. I mean, that's the true deal, real deal. It's a placebo-controlled, randomized, blinded study as opposed to my initial study, which was just my own patients. I knew what they were taking, so I could have been, wrong. And it's showing the same results, exactly, or virtually.
And that's what's exciting about it.
Yes.
It's been replicated.
Yes.
So, I think your study was actually a good one.
I spoke with Alan Cash, who's the owner of this company that makes this stuff. I hope I'm not saying anything I'm not supposed to say. Maybe I'm going to change how I said it. So he has other studies going on in ALS and in breast cancer for fatigue, and the results in the breast cancer patients post-chemo, post-radiation have been amazing in terms of fatigue. So it's not limited to ME/CFS patients. Why would that be true? Because we all have mitochondria, and they all get screwed by the things we do to them with chemo and radiation and everything else.
That is 100% true. The mitochondria, I feel bad for them.
I love them. I think it's the coolest thing ever. 1 billion years ago, this bug comes into our cells.
They are really cool.
How amazing is that? They even have their own genes.
I know, but we have to treat them well.
They only come from the mother, right?
No, I told you. Yes, so they only come from the mother. But the problem is they've given up their autonomy. So now they rely more on the nuclear genes than their own genes. Right. So now it can come from the father as well. So not everything is a mother's fault, David. I told you that 100 times. But
actually, I wasn't blaming the mother. I was grateful to the mother for giving me my mitochondria. Thanks, Ma.
I am finding a lot of mitochondrial. So I do we talked about this a little bit on the mitochondrial podcast, but I do a whole mitochondrial workup now, and I am finding, in fact, now I'm getting more and more requests for muscle biopsies for mitochondrial workups, and also for that particular protein that was found in that recent article, the WASF3.
Are you able to look for that protein?
No, it's not. I keep telling people it's not. They ask me for it, but it's not commercially available.
But what are you going to do with those results?
I'm going to prove that there's a mitochondrial problem.
Yeah, well, we know there is, even if it's not evidence-based. Yeah.
And, well, it just, it
Sorry.
That's putting me on the spot. So, it's sort of like everything else that we do, right? I like to confirm diagnoses. I don't like to just do a lot of hand waving, right? Which I think a lot of...
But the Mitoswab was doing that.
The Mitoswab is a functional assay, and now I now go more towards that Baylor one, which I find a little bit more comprehensive. But Mitoswab is just a lot easier to order because they're a private company as opposed to like a big institution's lab. It's a little bit of a harder, right? And it's just a swab, exactly. So I still will occasionally use the Mitoswab. I like to trend it. It's just a point in time, as I always say, like how you might have had a really bad day yesterday. Maybe you had a concussion or you ate a lot of bad food. Now your mitochondria are not struggling. So I like to trend it more than just relying on one Mitoswab. So I trend it and just sort of see how the enzymes are functioning. But I do like to sort of see how the mitochondria are working and get a sense of it, because I do think that while supplements are not the answer, I think there are some medications that are, I like the Rapamycin. We're going back to
I'm sitting here waiting for my opening so I can bring it up.
I know. I really like the Rapamycin for mitochondria.
Okay.
I really do.
So I'm sorry that I put you on the spot, but the intent of that, or what
was for me to say Rapamycin.
Where I'm coming from is we already, I want to say this in the right way. We know that it's all about the mitochondria, stupid, okay? It's all about the mitochondria. And yes, I don't know what it is exactly. Is it Bob Navio's mitochondrial problem, or is it Peter Attia's? I don't know. And yes, I would love more data, but muscle biopsies are invasive and expensive, and I'm not sure what I can do about those results, which leads me to the rapamycin. Okay?
Right.
So we're sitting here saying supplements probably aren't getting anywhere. One of the miracles about rapamycin is it actually gets to where it needs to go in these ridiculously tiny doses, and it appears to actually be able to deal with some of this underlying stuff, or a lot of it. I mean, that remains to be seen. And I am prescribing it. I think you're prescribing it. I'm hopefully starting a trial, working with somebody who may actually have a biomarker, which would be like a miracle, okay? But at the end of the day, the science behind what it does is so awesome, and I don't use that word much.
I know.
That how could we not be trying this, okay? And I think that statement is relevant not just to ME/CFS and Long Covid, right, but to many, many other diseases. And the point is that rapamycin, the push regarding rapamycin is coming out of what's being studied and learned in the anti-aging longevity space, as they say, okay, as a protective agent, okay? What can we do? This is what people care about. What can we do to live longer and stay healthier for a longer period of time? So that may sound like a ridiculous concept to even spend two seconds in a podcast devoted to complex illness. I mean, many of our patients are just hoping they're okay in a year, let alone live an extra 10 years. Right. Okay.
But I honestly think the longevity world can learn a lot from our patients. But go ahead.
They can. But I've
actually written to people like Peter Attia, and even to some of these longevity experts that are well known and are on social media and stuff like that. I've actually written to them like, let's have a conversation, because I've got patients with such severe ME/CFS that I think you can learn about longevity from them, and they can learn about, and I could learn about how to treat them better from you.
That's my point. That my argument here.
And they never get back to me, by the way.
Yeah, of course not. My argument, or the hypothesis, for which I have zero data at the moment, is that the pillars of aging, and there's now 12 or 13 so-called pillars of aging, and don't ask me to list them, are the things that lead to the diseases of aging, which are dementing illnesses, neurodegenerative illnesses, cardiovascular illnesses, osteoarthritis, et cetera, that all of those are the same thing that's occurring in our patients to a degree prematurely. And and that means systemic ongoing inflammation, and this problem with something called autophagy. And if it works in the aging population to reduce aging, and that's been proven in animals at any rate, mice and dogs, then why wouldn't it be helpful in our patients? And that's the argument, I think. I
completely agree. And I very regularly have prescribed it, and I'm doing more and more so recently, for sure.
Yeah.
I think it could be one of those magic drugs that really help a lot of patients, not all of them, but a lot of patients. And the more we learn about it, the more I seem to continue to conclude that this is a potential drug for a lot of my patients. And so what I still think you have to correct the anatomy, of course, but then how are we going to correct all the damage that's been done? And that's where rapamycin plays a role.
And it's not the first thing to do.
No,
right?
Definitely not.
I keep using this low-hanging fruit terminology because that's what it is. Those are the things that should be
right.
looked at.
I mean, I have to say that I know there's a lot of conversation about like, okay, what's the first-line treatments for POTS? What's the first-line treatments for MCAS? I become more and more disillusioned all the time because I feel like these first-line treatments just don't pack enough punch for these patients. They don't.
Well, yeah, I agree.
I mean, but I feel the need, I guess, just because standard of care, all that nonsense that we were indoctrinated over.
Larry would say, which is, well, give them an H1 and H2 blocker first. And I still do it.
Yeah.
But why aren't I giving them?
I feel like, listen, to be completely frank and transparent, I feel like they come to me, people pay me money. We've talked about the reason why we're cash, and we had to dump insurance companies a long time ago. They don't need to hear me say, take some Claritin.
Right.
That's not what they're paying me for, right? I think that they're paying us to think harder, think longer, and do things that are beyond what they can buy off the shelf at CVS.
Well, wait a minute. I think that the antihistamines and H2 Pepsid have potential benefit. I just think
I don't doubt
once
it.
I've made a diagnosis of mast cell activation syndrome, either clinically in my brain, or if I'm lucky with biologic, microscopic confirmation or a lab confirmation, we should be jumping to the second and third level drugs. Because
completely
what's
agree.
the point of shutting the door after the horse is out of the barn, which is what the receptor blockers do.
Right. I completely agree.
But my
and as you know, I also think that it's not just about the histamine. I mean, many of these patients don't even have histamine kind of reactions.
There's 1,000 chemicals coming out.
Exactly.
So, and my point about the low-hanging fruit was part of the injury to the mitochondria, which rapamycin may help, it's not going to help as much if you're hypoperfusing all of your key core muscles, core organs, and brain, and if your mast cells are releasing 1,000 cytokines that are totally screwing you up, and if your gut is so leaky that your brain is now leaky and everything's messed up. So if we want to see benefit from a potentially magical drug, we need to level the playing field. We need to make it fair to rapamycin to show its stuff.
I agree with that. I agree. And, and there are those patients that I think do respond to those first-line treatments. In fact, I had a new patient just yesterday. She's a young girl. She has been diagnosed already with POTS, with MCAS, and so on. She has been managed very well by her primary care provider with first-line treatments and says, very honestly, I don't have much POTS symptoms any longer. I don't have many mast cell symptoms any longer, but I have just this unrelenting fatigue. Okay. She denies it's PEM, by the way, because I specifically asked that question, and we sort of went through some of her experience with what she's referring to as fatigue, and she's right. It's not PEM. She's a very smart young lady. It's just this unrelenting fatigue that she even though she sleeps 9 to 10 hours a night, she wakes feeling unrefreshed, feels exhausted during the day, does work, but that's all she can do. And
so she's a perfect potential candidate for oxaloacetate and or rapamycin.
Right, and that's what I told her. Yeah. So I told her she needs oxaloacetate. Right. And we talked about rapamycin. I didn't prescribe it yet. It was my first visit with her. I tend not to do that off the first visit. I do like to do my workup first, so we're doing a bunch of labs and stuff like that. But it's just this fatigue. And again, in the first part of our PEM episode, we talked about this is not fatigue. PEM is not fatigue, and fatigue is not PEM. They're two separate symptom entities, in our opinion, right? You agree with that, right?
Yeah, totally.
Just want to make sure.
Yeah.
So, and I think, but I still think that there's an underlying common denominator of the mitochondria. Right. And so we talked about oxaloacetate, and we did talk about rapamycin, didn't prescribe it yet. We talked about some other things, but I'm doing a big workup. But my point being, the reason why I brought up this particular patient was because her POTS are fine, according to her. Her POTS are fine, her mast cells are fine. And I asked a lot of questions for those diagnoses, and they were all well managed. So
she's a good
by
example
first-line treatments.
Of what we're both saying, which is if she was new to you and her POTS wasn't fine or MCAS wasn't fine, it wouldn't be not appropriate. It would be less likely to be effective to offer her oxaloacetate and or rapamycin so early until you get better control.
Exactly.
I mean, that's the argument I make with patients to their frustration when I say, I'm not going to treat your Lyme disease or your Bartonella until I can safely know that you can take the drugs for that. We need to control your MCAS and your
that is a big problem with mast cell patients, is that they have a really difficult time tolerating most meds. Yeah. They either have poor tolerance and get lots of side effects, or they have paradoxical responses. Right. And so that's a huge challenge. So when the mast cells are controlled, then that's less of a challenge, but it still can be a challenge sometimes, just because you never know what the excipients or the fillers are in any of the medications or even the supplements that they're taking. But, sorry.
No.
Okay. But back to the mitochondria. So I agree it's about the mitochondria. What specifically is pissing the mitochondria off, I think, is still a little bit unclear. Yeah. Because we don't really understand the reason for this ME/CFS. And we know that it's obviously there's a viral component, there's an exposure component. A lot of these patients with mold exposures or some other environmental contaminant or toxicant. Right, just the environment. Sometimes, even these big lights actually can sometimes cause some symptoms. Certainly like even temperature, patients will say that they got sick when they were in very humid environment, when living in humid environments or living in very hot environments. And cold is not as much as a problem as I hear that heat can be for a lot of patients. And so what triggers something and what are the subsequent physiologic changes that result in this ME/CFS septat kind of picture, breakdown of connective tissue picture is, different to each individual patient. And so it's really about trying to investigate and be a detective and trying to figure out, okay, what specifically is pissing your mitochondria off? Environmental medicine, 101 is like remove yourself from the exposure, but that's obviously very hard to do if, one, you haven't identified it yet, and two, even when you do, how do you remove it when now it's internal, right? It's an internal milieu problem, and so now you have to sort of fix the toxicity that's gone on internally and endogenously, which can be a real hard thing to do. So that's why they're on all these medications, they're on all these supplements, and we have to I feel like I have to just sort of sometimes, move the weeds out of the way, right? Because there's a lot of weeds in these patients when they finally come to people like us, I think. In all fairness, I think they try to use their insurance first, which I totally understand. But by then, though, of course, now they've been on lots of different meds, lots of different supplements. They've had lots of different testings, usually not the appropriate testings, So we have to sort of start from scratch at the same time, try to remove a lot of the garbage that's been placed upon them with not only meds, of course, but supplements. I mean, a lot of them have polypharmacy, and that could be a problem of its own. So my point is it's very complicated and complex. There's also been some studies done in rats and mice that sort of show that and this wasn't in ME/CFS rat models. This was in other neurodegenerative disorder rat models, but found that there was evidence that the motor cortex was hyperactive, basically. They put electrodes in and found that there was excessive activity of the cortex. And so when the motor cortex is activated, of course, it activates muscles, right? It's how we move. And so then I think, well, if the motor cortex is hyperactive, then is there hyperactivity of muscle function? And as you know, a lot of these patients will report spasms, muscle pain even, myalgias. And so I wonder if there's a central component to this. You think about the muscles and the nerves, peripheral, that's a peripheral problem, right? A peripheral nervous system issue, which is neuromuscular medicine. But this study that I actually shared with not our mast cell listserv, but with our ME/CFS clinician committee, I once shared a while ago, and I'm like, hey, look at this, and everyone was like, oh, that's sort of interesting, but it didn't go anywhere. It was one study. So, but I can't help but get over that study because it showed a central component to what might be excessive muscle activation. Therefore, as you know, the muscles are very metabolically active, so have thousands of mitochondria, just like the brain does. I'm really poor grammar. And so now the mitochondria are just overworked because the muscle is overly activated, but it's overly activated because the motor cortex of the brain is overly activated.
Following orders.
So now there's a central component I have to worry about, but there's no the MRI is not going to show that, right? I'm not going to start putting electrodes into people's brains. Clearly, these were rat models. It wasn't even replicated in humans because there's really no way to do so. But again, it just speaks to, once again, this idea that we know so little and we have so much more to learn so that we can better treat and come up with management plans for these patients. So it's not just peripheral, it's central.
Yeah, well, it's everywhere. That was what we were trying to say in the previous episode about post-exertional malaise, and that doesn't have a single cause.
No, it doesn't.
And it really is a systemic sickness.
I like that. That's a great way of characterizing it. It's a systemic sickness.
So, although this is not supposed to be dedicated to rapamycin, I want to go back to it.
No, yeah.
I want to make a link here. So, I said that I think there's a key link between the pillars of aging, diseases of aging, and complex illness patients, which is basically systemic inflammation. And that systemic inflammation in the aging population is caused by a decline, a decrease, a biologic or evolved decrease, not a good thing, of autophagy. Autophagy is this biologically evolved process in which we have organs or organelles called lysosomes, which eat crappy zombie cells that should have died that didn't. So we have a mechanism for cells to commit suicide called apoptosis. That mechanism becomes rusty, becomes dysfunctional as we age, or in other, my argument, in other inflammatory illnesses. And then those cells hang around and they are releasing, not only is it bad they take up space, not only is it bad that they consume nutrients that normally would be recycled and used over, right? We have the perfect recycling system. They actually go ahead and make everything worse by producing these chemicals which injure surrounding cells and cause more inflammation. So it's kind of a perfect storm of really, really bad shit. Right?
Yeah.
And rapamycin, by inhibiting mTOR1, promotes autophagy. That's the key concept, which is not very complicated in some ways.
Not at
we
all.
don't quite know how it does that necessarily. And by promoting autophagy, now you kill those cells. You eat them up in your lysosomes, you recycle their proteins, and you stop these bad chemicals from being synthesized and produced by those zombie cells, causing more injury. So it's been pretty well proven in the animal models, in mice models, and now in dog models, and in an ongoing dog trial with, I think he said he has 800 dogs, Matt Cameron,
Wow.
something like that.
Those poor doggies.
And it's tons of anecdotal evidence in the aging population, people who just decide to try it. And so I think there's a relationship, and I think it's about this concept of autophagy. And the reason I'm talking so much about it is that's a systemic process. It's happening here, it's in my ears, it's in my kneecaps, it's everywhere. And if it's messed up, I have to work so carefully with my language. If it's messed up...
You're doing a good job.
Oh, God, it's really hard. If it's messed up, we pay a price. And why our patients have abnormal autophagy, which is what I think, and I'm hoping with this other trial I mentioned, we will prove that with this biomarker. Why they have it, presumably, is some genetic issue, some connective tissue risk factor, and then infection, and then all the other parts of the septet. And that's why I'm so excited about the drug.
Yeah. No, can you share what biomarker it is?
No.
Oh.
I mean, I don't have permission.
Got it. No, that's fine.
If I did.
Understood.
But it really looks interesting.
No, it's exciting, actually. Yeah, I'm looking forward to learning more. I completely agree with everything you said, and that's exactly how rapamycin works. And we've actually known that for a long time. We've used it, as you know, for lots of different diseases. Yeah. This is not a new drug.
Yeah, I was just going to say, so it just literally celebrated its 50th anniversary.
Yeah.
I mean, the story is unbelievable of rapamycin. I won't go into it. And it initially was used as a transplant drug, and still is, to reduce to cause immune suppression to prevent rejection of organs. And I always have to kind of go through that with patients because they think I'm insane when I say, let's use this drug. But it's also being used actively in many different cancers and trialed in many, many other cancers. So this is not like a new guy on the block.
Right, but even how it's used in cancer and how it's used in growth disorders like tuberous sclerosis also applies, because what it does is it prevents the replication of bad cells, basically, to put it simply. And so a lot of, chronic illness has damaged cells that still have the ability to replicate and just creates more damage and more fodder for inflammation. So the rapamycin actually helps to prevent the replication of these damaged cells, which can further contribute to aberrant physiology and further contribute to just a lot of the progression of these diagnoses that they have. So I can't say enough good things about rapamycin, about what I think of it for our patient population and the benefits that I see. And, and I often explain, patients, I think when I put them on it, I think they expect to feel a certain way. It's not about all of a sudden you feel like you can go out clubbing. As if one of our patients are trying to do. I don't know why I said that. It's not like I go out clubbing.
MECFS club.
I think they just expect to feel a certain way, but what I try to explain to them is that you're not going to feel a certain way from it. What it's meant to do is to sort of calm the inflammation to prevent progression of the disease. And then once we get you better by managing the symptoms of the different diagnoses, it's to keep you better. Right. And so that's the goal ultimately with the rapamycin. It's not that you're going to take it and then all of a sudden you're going to feel like you could, climb a mountain. So,
I mean, there's a couple of things we should disclose, the tricky parts here. Number one, I don't have a shred of proof for everything I just said. I don't have a placebo-controlled clinical trial that says two populations of ME/CFS patients, one's going to do better than the other.
Right.
That's what I'm hoping.
But that's
what I'm
hope.
hoping will happen.
I agree.
Okay.
That's what I want to happen.
Right. So that's the biggest disclosure. The next is we don't really know the right dose. Okay, in any of these things, in anti-aging or in our patients or in dogs or in mice. Okay, we are using certain doses that are sort of consensus. It's what looks like it works with the least side effects. Next, what you were just saying, some patients actually do feel something pretty quickly.
They have less. I will say, when I was saying that, I realized that some patients report less pain.
Right, they'll have less pain.
Yeah,
I've had patients
so that,
with
yeah,
less
that is
fatigue,
true.
less brain fog. But many patients will not feel anything, which doesn't mean it's not working. You can't feel autophagy. It's
that was
like
my point.
I wake up and I'm autophagy primed or something, and I can feel it, you know?
I'm autophaging.
Right, that's what I was trying to come up with a word. So that's hard. The great news is the drug is remarkably side effect free.
Mm-hmm.
Kaberlin in this podcast talks about a study he did and just published with thousands of people who are taking it. So they're mostly older people, like me, taking it. And he had a long questionnaire, and he matched it to a population that wasn't taking it. So well matched, okay? By age, sex, comorbid conditions, stuff like that. Literally, there was only one side effect in the treated group, and all of the other side effects that were listed, do you feel this, that, and the other thing, were worse in the placebo group because they're related to inflammation. So there was the only side effect that occurred at all with more frequency than placebo was mouth sores, these canker sores or aphthous ulcers, which can happen. It's not terrible, but they're not pleasant. But that's pretty remarkable if you think about this drug.
Was there any sort of theory as to why they were more predisposed to the canker
Probably
sores?
because these are rapidly turning over cells, our oral and gastrointestinal epithelium, and so it's slowing that down. That's part of what it does. It decreases proliferation, and that may be the reason. So you get a tiny injury. All day long we're injuring our mouth as we eat and chew and talk so much, and it repairs quickly. I mean, I'm sure people have experienced you'll have a little, you bite your cheek, and by the next morning it's better.
Right.
Okay? So I think that's the reason. It doesn't happen to everyone. It's only, I think it was like 5% or something. So.
Those are really unpleasant.
Yeah, but you can actually use an oral dental paste with steroid in it, and it gets it better almost overnight.
All right.
So, I mean, what I'm trying to say is it's a little cowboy-like to be using it because it's off-label. I don't have great proof. But like everything else you and I do, when we prescribe drugs, everything we do is off-label, and most of it is out kind of frontier cowboy land, and we make our decisions based on risk and benefit assessment.
Absolutely.
And it's got
and we monitor appropriately, frankly. I mean, so
look at me. I'm giving out imatinib and hydroxyurea for mast cell. Those are chemotherapy drugs. There is risk. So to me, rapamycin is it's a no-brainer to make.
I think it's less risky than some of those other. I mean, I use immunosuppressants all the time, and I'm constantly monitoring. So I think rapamycin is less risky than some of than many of the drugs I prescribe. So yeah, because I'm like I've already said, I'm sort of beyond the take some Claritin.
I know we need to finish, but just in terms of data, because I said we didn't, we do have data on other things about it. So the landmark trial in 2007 by Joan Manick is when she gave rapamycin to, I'll make the numbers up because I don't remember, 60 people over the age of 65 and placebo to the other 60, and monitored their response to flu vaccine and monitored the incidence of viral infections in the next 12 months after they stopped the drug. And the treated group had a much higher response to vaccine, much lower incidence of flu, and for 12 months had a lower incidence of viral infections. That's a very solid trial. That is very huge
solid.
Placebo randomized
That is
control.
Important information. Yeah. We should, that's something that we should do on some of these podcasts, which is that while we do a lot of, as you say, cowboy stuff, cowgirl stuff, there are studies that in some ways do support the reason why we even consider doing what we do. And I think that might be an important piece of data that we can bring to when we talk about treatment plans that we work with for patients. So,
Yeah. Well, again, I'd love to figure out a way to post these papers.
I know. God.
And
I told you it's my New Year's goal, my New Year's resolution, but that's 2024. We're only October.
Right.
But I will figure that out eventually.
But you're right. It would be good to simply
Yeah.
compile a bibliography that I give out in an
I agree, because I think maybe we're giving the impression that somehow we just pull these things like out of a hat without thought.
Yeah.
And the truth is there's a lot of thought that goes into it. And some of it is because of the studies that we read that may not be directly related to our patient population, but have findings that we apply to our patient population just because of what we know about them.
I mean, just picture.
Yeah.
I will let the audience picture, people listening. There's 475 doctors and clinicians on masterminds.
Right.
They all are constantly posting papers.
Right.
I get papers every day from my patients. So that's 2 huge pots of papers. And then there's what I find and read myself. So if you were to look at my computer, there's a reason 50 windows are open, or tabs, or whatever the hell they're called. On the top, there are papers that I haven't gotten to read yet. So yes, we sound a little bit shooting from the hip, cowboy, cowgirl, but it is based on an enormous consumption of data and literature and references.
And I think that's a point where we don't bring home, we don't drive home enough. That we're just not pulling it out of the air.
Yeah, exactly.
It does come from a lot of reading and a lot of consideration and a lot of even discussing. So I think bringing up studies like this is sort of an important piece of data that we should bring forward.
And that's why the episode on that paper was so great, the endotoxemia paper.
And we'll do more of those for sure. But
all right,
we're done. Did we even talk about PEM?
So that's PEM in 25 words or less.
I think we did. Everything we said really does relate to PEM and sort of how we think about it and how we approach it.
Right.
But we'll obviously continue to revisit this topic many, many times. So thanks for joining us.
Thank you. Send your questions.
Yes, please.
Invite your friends. Invite your doctors, please. We don't have enough doctors watching.
Yeah, we need more doctors because we want to educate doctors to help the patients more. Right. So have a great day, everyone, and we will see you soon.
Okay.
Bye.